Hello everyone, I'm Kirsten Pilati, the CEO of Breast Cancer Network Australia, and welcome to one of the most popular webcasts we have already had to date. Hormone blocking therapy, is it really worth it? And I think it's a question many of you are asking in the middle of the night as you're having to change sheets for the third or fourth time, but we'll get to that later. Firstly, I would like to pay my respects to the elders past, present and future of those Australians who were here first. And I thank you for being part of our network. You're a really important part of our network. So tonight we have some amazing guest speakers. We have Dr. Rick DeBoer and Professor Martha Hickey, who are specialists in this area of hormone therapy. But before we get underway, it is always so important for us to base all of our discussions on the needs of those members who we represent, women and men who've been diagnosed with breast cancer. So Kate Keogh-Murray, take it away and welcome.
Thank you, Kirsten. Good evening. I was diagnosed with estrogen receptor positive breast cancer 18 months ago. My breast surgeon told me that this was a good thing, as I could take one of the miracle hormone blocking drugs. Didn't think anything more about it until several months later when I was doing chemo, and I was discussing with my oncologist some of the usefulness of various supplements that I'd heard people talk about, and she casually had dropped that one might be helpful later with the bone pain you'll have. Say what now? I was to go through all of this only to suffer from bone pain for the next 7 to 10 years, and I really was quite upset. So I queried my oncologist about what she meant by the bone pain, and she explained and then added, when you come off this drug, you'll probably have these aches and pains anyway, and laughed. And I did not laugh, and I'm still not laughing. So I started reading up on endocrine therapy, and it became clear that while some people took it without trouble, others had a lot of problems. And so much so that some people stopped taking it. And I also read that this therapy has one of the lowest compliance rates of any drug going around. Perhaps you can confirm for me that later on. So crossing my fingers that I'd be in the group that had no trouble with it, I took my first letrozole on Friday the 1st of June 2018. Nothing happened for 3 days, but on Monday the 4th of June I woke up with sore ankles, and they've been sore ever since, 24 hours a day, 7 days a week. It regularly prevents me from falling asleep and sometimes gets so bad that it wakes me up. Now, I'm aware that a lot of this is going to sound like whinging, but as an illustration, here is my list of current letrozole side effects ticked off against the list provided by the manufacturer. Bone pain in my ankles, bone pain at the base of my thumbs, bone pain in my elbows, soft tissue pain in my elbows, joint pain in my hips, knees, feet, toes and fingers, stiffness in all those joints after periods of inactivity longer than a few minutes, dry mouth, dry eyes, mucosal dryness, a prickling, tingling sensation in my left ear, fatigue, depression, anxiety, constipation, nausea, hot flushes, insomnia, memory impairment, thirst and dry skin. Now, I understand that some of these can be put down to menopause, something that I was not in before I had breast cancer. But if one more doctor tells me that these could be happening anyway, I shall scream. They were not happening before I had cancer. Most of them were not happening before I started on letrozole. I know my body. I know what's normal for it. It's especially galling when the doctor who's telling you is not menopausal. They have no idea of what it really feels like to have less estrogen than an 80-year-old. My prefacing that list with a comment about whinging was deliberate. One of the burdens of taking hormone therapy drugs is that everyone around us expects us to be back to normal and grateful to be alive. This is actually said to people. So if you complain about living with chronic pain or the frustration of, say, having dandruff for the first time in your life, it all seems petty and we feel guilty, and that just adds to the difficulty of these drugs. It's a psychological burden as well as a physical one. There's been a lot of discussion about the challenges of the hormone therapies on the BCNA online forum. One of the cries that always comes up is, I didn't feel sick before I had cancer, I've been successfully treated for cancer, but why do I now feel so rubbish when I'm supposed to be better? For those of us who suffer from the side effects, our quality of life can be poor to ruined. For some, it's ruined so badly they're unable to work, use their hands for hobbies or housework. They're so intensely memory impaired and depressed that they stop taking the drug altogether and then live with a heightened risk of the cancer returning and the possibility of self-blame. the belief that if it does come back, it will be their fault because they weren't able to hack the side effects. It's a pretty horrible thing to have to contemplate. I realise that some of our issues with life on these drugs are caused by expectations. The PR around breast cancer is 90% survival rate, happy survivors running marathons, doing fundraisers, etc. The implication is that we are cured. Once you're in this machine, you realise that there's no cure, that NED is the best we can get, and that the cancer can come back at any time, even a decade or more later. And here's a drug that may help you, and it may give you difficult side effects. On your way, dear. Expectations unmet. So, questions. These drugs have been available for many years. Is there anyone out there looking for better ones, studying how to improve them? When the many thousands of people report back to their doctors the problems they're having, what happens to that information? Is it ever fed back to the manufacturers, the researchers? We're not a minority group. 70% of breast cancers are estrogen receptor positive. The internet is littered with hormone therapy support groups full of people reporting the same symptoms. Some more big questions. How good are these drugs? Do people develop resistance to them? Is there any way of knowing if we're suffering for a reason, or is it like chemo, weeding the garden with a flamethrower? If I'm going to persist with the pain and the depression for 9 more years, what are the reassurances that this is going to work for me? And that's a very specific question, because my sister took tamoxifen and her cancer came back and she died. So we're dumped out the end of active treatment with little to no support. The breast care nurse moves on to other patients. You see your doctors less and less, and everyone expects you to move on with your life. We expect to move on with our lives. Too many survivors report telling their doctors about the side effects and being met with shrugs. You can try that if you want, but there's no evidence that it works. Many women report not being believed when they seek help from their doctors. Why isn't there more information out there about things to try, things that have been definitively proven that work or don't? We need accurate information delivered to us in a timely and supportive fashion. The title I was given for this talk was Hormone Blocking Therapy, the Challenges I Have Found. So, to summarise, my challenge is to get out of bed in the morning without grunting in pain, to have the energy to properly care for my household, to have the energy and the time to attempt to manage the side effects, walking, weight-bearing exercise, stress management, etc., to have the fortitude to continue to move as each movement involves pain, to not cry in front of my children, to manage my fatigue because I'm woken constantly by nuclear-grade hot flushes all night, every night, and to maintain a thirst for life because, frankly, sometimes it's hard to see the point. Please don't tell me my case is extreme. I know so many women who have exactly the same list as I do, and worse. So, 10 years on this stuff, is it worth it? I look forward to hearing what you have to say. One more thing. My instinct, I realise that was all quite emotive, but my instinct is to apologise for the tone of that, but I'm not going to because it reflects how difficult my life is and how difficult the lives are of the many people on these drugs. Thank you.
Thank you, Kate, and as always, so great at articulating some of the very thoughts of our members across the country. So I've loved that. Now, before we do go to the specialist to respond to some of the questions and that Kate has put out there, but also some that have come through our online network, I want to encourage people to send through their live questions now. Now, a bit of a tip, make sure you say your name and where you're from so that we can really make sure that we can answer those, but also get a good feel of how many people across Australia are watching this very live and very real webinar full of emotion. So, Dr. Rick de Boer, no pressure now to deliver on some of these. I will pass you your controls and welcome. Thank you so much.
Thank you, Kirsten, and thanks very much for the invite for tonight. And thanks, Kate, for her story, which sadly is not unique. And I'd just like to point out, I'm not her oncologist.
You would
I'd be in big trouble. So I was asked to cover some of the areas of hormone blocking therapy, or also known as endocrine therapy, or often called hormone therapy, because it's sort of quick to say, but it's actually anti-hormone therapy. So some people get confused because hormone therapy is really HRT, which is the exact opposite. And it's a really complex area. There's lots to talk about, but I've got 10 minutes, so I apologise if hopefully I won't go too quick or there's too much information. But there are lots of questions that women have and should have when they're looking at starting anti-hormone therapy or they're recommended it. First question always is, do I really need it? And I think that's a really important question. Not every single patient with a hormone-positive cancer may need anti-hormone therapy, depending a bit on the type of cancer they've got. which tablets should I take? There are a variety of them. There's tamoxifen, there's the aromatase inhibitors, of which letrozole is one of them. What are the main side effects? Does everybody get the side effects? What about after 5 years? I keep hearing about 5 years. Now I keep hearing about 10 years. You know, and then all the different side effects. And I've just listed 3. This page could go on and on and on. But hot flushes is obviously one people think about a lot. Osteoporosis is a very scary thought for the young women out there. What if I want to get pregnant? What's the story around that? And there's lots of other things. Some will be covered hopefully by Martha, and certainly in the questions I'm sure we'll get some things, and hopefully we can talk about that. I often put this slide up when I see a new patient, not the slide, I draw this out because hormone therapy is not for every single patient because breast cancer comes in different types. There are 4 main types that a medical oncologist thinks about. And you can, I hope it's not too confusing, but if you look at the top 2 boxes, you can see there are 2 types of breast cancers that are called hormone positive. They have estrogen or progesterone receptors. And it's about 75% of the patients that I would see on average. And some of them are also HER2 positive. That's a small group you see in pink there. But the majority of patients, if they're hormone positive, their cancer is what's called HER2 negative. But it's the patients on the top line that we think about anti-hormone therapies. So just as a backup here, because I know out there there'll be people that are have not hormone positive cancers, but generally anti-hormone therapy is something we think about and talk about for the hormone positive patients. Chemotherapy is very important to think about and talk about if you've got a hormone negative cancer, the 2 on the bottom. And there's anti-HER2 therapies that are really useful if you've got a HER2 positive cancer. So it's quite confusing, but if you're not sure which of the 4 you've got, really important to talk to who's looking after you so you do understand it, because it helps drive some of the recommendations. Now this is complicated, and I'm sorry about this, and I don't have time to go through it, but I was asked to show a diagram of how all of these things work. And again, this is something that if you haven't gone through, someone should go through in their own way with you, just to highlight that the hormone system is quite complex. There's the messages coming from the brain that go to the ovary. Estrogen is the key. You can see there in the little yellow box there, and it comes out of the ovary primarily in younger premenopausal women, and when a woman goes into menopause, the ovaries stop working. But one of the things a lot of people don't realise is there's some estrogen that is made in the body, particularly in the fat cells, and that comes from hormones that are made by your adrenal gland. So even at the age of 100, there's a little bit of hormone being made. And that hormone, unfortunately, can stimulate hormone-positive cancers. And you don't need very much estrogen to stimulate a hormone-positive cancer. Hence why, you know, the treatments, and you can see there the tamoxifen that acts directly at the cancer, or the aromatase inhibitors such as letrozole or anastrozole, they stop the production of estrogen in women who have gone into menopause. So if you're 25 or 35 with a hormone-positive cancer, tamoxifen could be a good option. You sometimes can use the aromatase inhibitor depending on other things, but if you're in your 60s or 70s, you could use either the tamoxifen or the aromatase inhibitor. And one other thing I was thinking about Kate is, if I was seeing her, the first thing I'll talk about is, are there other options rather than the letrozole? So why do we even recommend tamoxifen? I mean, this is very old information from the old days where tamoxifen in the original trials was compared to no hormone therapy. And basically, again, I don't want to go into great detail, but the bottom line was, if you look at in terms of recurrence or in terms of, you know, I suppose the bigger picture, death from breast cancer, the women who took 5 years of tamoxifen, you improved at 15 years, 9% extra patients were cured by adding in the tamoxifen. So we see that as a big number, and if you're treating millions of women across the world, 9% is a large number of women who can be cured with the addition of tamoxifen on top of their surgery and radiotherapy. So this was the sort of information that drove at least the start of why giving tamoxifen, and the original trials looked at 2 years and then at 5 years, which is sort of where for many years the treatment recommendation was. Now, about 20 or 25 years ago, there were the development of these drugs called the aromatase inhibitors, the letrozole that Kate is on. Now, these drugs only work in women who are in menopause. They block the production of estrogen. They're extremely effective at that. But basically, as Kate said, you have less estrogen in you than an 80 or 90-year-old would. So they're very effective, but they can be very difficult. The body doesn't particularly like that. But you can see all the trials that were done comparing them to tamoxifen. Tamoxifen's in blue, and the other colours are the aromatase inhibitors. Lots of different trials using lots of different strategies, up front, crossovers, afterwards, lots of different things. And the bottom line was that why they're used or why they're recommended, and I use this slide. So the blue line you see now is what happens to women in terms of the chance of cancer coming back if they take nothing for their hormone treatment. And what it shows there is at 5 years, about 30% of patients got their breast cancer back. In the trials with the aromatase inhibitors, the white line was the tamoxifen in that trial. So straight away you've gone from much higher. So we're definitely making a difference there. We are helping people, but always point out to patients, 70% of the patients at 5 years, even if they didn't take anything, their cancer hadn't come back. So again, to say that without it you're doomed is not true. It does improve things a lot, and that's why we recommend it, but maybe it's not completely for everyone. But you can see the difference there for the yellow line. So that was the extra benefit that a drug like letrozole gave over tamoxifen in someone like Kate. You can see it's about 3% or so benefit. So it's not amazingly different, but it certainly was an improvement. And again, if you're treating hundreds of thousands of women in a country or across the world, a 3% improvement is something that's worth certainly at least thinking about and discussing. But I usually use this information sometimes to say to a patient, the difference really is between taking something and nothing. And which something you take, we should work out that suits you the best. Unfortunately, this hasn't come out exactly as I wanted on the slide, but that's okay. One of the difficult things to talk to patients is hormone-positive breast cancers do have a long, sort of concerning chance of relapse. Sometimes you do see people, and I'm sure you've heard of people whose cancer has come back at 6 years or 8 years or 12 years. So once 5 years of treatment was sort of established as something we talk about, the next question was, should we treat for longer for those patients who are at risk of getting their cancer back later? And this is the sort of information that's come out. This is on tamoxifen. There's a big study looking at 10 versus 5 years of tamoxifen. And again, I'm not going to go through it in great detail, but there's small but statistically significant, so a 3% improvement in survival with it. So this is a sort of, it's not amazingly different, but it's certainly important to understand it, to understand it's there and to discuss this with your patient. It doesn't mean that every single patient needs to go out for 10 years. It depends very much on the type of cancer you had and what risk it may have had. And with the aromatase inhibitors, they've done the same sort of work, looking at 5 to 10 years. And again, this is a complex presentation from a meeting last year, and I'd love to go through it in more detail. But basically what it showed was if you continue from 5 to 10 years, particularly if you had lymph nodes involved, then there was some real benefit. But if you had a cancer with no lymph nodes involved, whether to go beyond 5 years is a very individual question. It's not a blanket statement. When I hear people say, oh, everyone must go out to 10 years, that's not true. It has to be really individualised, and it's something worth talking about with your specialist when you come up to that 5-year mark, because it may not be necessary and it has to be balanced against the side effects. So this is a flowchart that I sort of put together looking at the questions and the decision points, I suppose. So this is for postmenopausal women, so women who've gone into menopause. And I'm not going to go through them all, but you can see there's lots of different points where we can have discussions about what to do. And the green arrows are whether to go onto tamoxifen and stay on it, and the blue arrows are whether to go onto a drug like letrozole and stay on it. And you can see you can stay, you can cross, you could stop. Some people choose not to have any treatment at all. But you can see how it goes for 5 years, and there are more questions at 5 years, and there's even some questions at 10 years. There's some really interesting information about 7.5 years versus 10 years. So lots of things to talk about through that journey, and it's certainly not one size fits all. If you're premenopausal, it used to be very simple. When I first started oncology, it was the green line, and that's all we had, tamoxifen. It's become a little complicated recently because of information about turning the ovaries off as well as taking tablets. And I'm sure there's some people out there who are on that style of treatment or has been recommended it. And that's a very difficult treatment because you're making a 25 or 35 or 45-year-old woman instantly menopausal, which, as we've heard, it brings a lot of different side effects. So of those lines there, which ones to go on and which one's appropriate for you, again, is very individual and needs to be quite carefully thought through. So I think I'm running out of time, as I knew I would, but there's lots of side effects, and this is not the complete list by any stretch of the imagination. I think we've heard the bigger list, but these are just sort of some key things I suppose people do ask about and think about, but we could go through that at great length. The joint pain and stiffness is classic, unfortunately, side effects of the aromatase inhibitors, the flushes, the vaginal issues, fatigue, the brain fog, the sleep. I think 98% of my patients don't sleep as well as they used to. Absolutely. Weight gain is a massive issue as well, and lots of things to try and work through. And when we're trying to balance which drugs to use, so for someone like Kate would come, you'd look at the different positives at the top of the seesaw, and then you look at all the main negatives, but there's a lot more, and lots to talk about and think about, and to try and individualise for the patient. So just to finish off, when we're talking about anti-hormone therapies, we have to think about the sort of cancer you've got. Is it worth doing this treatment, and for how long? What are the side effects that you may get and that you are getting? And then also always important to think about what you can do to help yourself in that area. And certainly a lot of interest in exercise for some of those side effects. Diet is important, etc. So. Sorry, I've gone over time, so apologies.
Thank you so much, Rick, and you can see why you are one of Australia's leading medical oncologists, and we so appreciate you having to pack a lot of information into a short period of time. But I can tell you that the questions are coming through thick and fast, and Kate, there's a lot of acknowledgement that you have finally given and shown a story and a face to the issues that many of our members are feeling at home and really isolated about. So it's fantastic. So keep your questions coming through. Make sure you tell us where you're from. I can't believe the diversity already. So Martha, we're going to hand over to you now to talk about managing some of those common side effects. Thank you, Martha.
Thanks, Kirsten. And just to put this in context, I'm a gynaecologist. I work in menopause. The reason we've developed the service that I'm going to talk about and the research and the information is because a breast surgeon colleague, Christabel Saunders, came to me and said, we've got to do something for these women with breast cancer because nobody's doing anything. And I hope that what we've done now is helpful. So there are particular treatments, aspects of breast cancer treatment that we can manage and that are common. I'm going to talk about infertility, menopausal symptoms. I'm going to talk about sexual difficulties, sleep disturbance and mood disturbance. And I would say that probably a woman who's been treated for breast cancer, most women will have at least one of those symptoms and may require information and help in managing them. So infertility is a particular priority for young women with breast cancer, and about a quarter of those who are diagnosed with breast cancer in this country is still during their reproductive age. And of course, because we have start our children much later than we used to, many more women are being diagnosed with breast cancer before they've started or completed their family. For some women, their chemotherapy treatment, their periods stop after that, then they may start again. But at the moment, we don't have any reliable ways to say to a woman whether or not they're going to be fertile after their cancer treatment. But we do know that even if periods return after chemotherapy, that fertility is still reduced. So in terms of what can be done, there's some evidence that injection with a drug called Zoladex prior to chemotherapy might protect fertility in some younger women who have breast cancer prior to their chemotherapy. It is possible to do what's called fertility preservation techniques, so that might mean collection of eggs or embryos to be frozen prior to cancer treatment that might increase the chances of a future pregnancy. New regimens for doing that don't require delays in cancer treatment. And it is possible to collect ovarian tissue that's then frozen with view to reimplanting that at a later site. But there have been less than 200 pregnancies worldwide in those circumstances. And as a general rule, I think that chemotherapy for breast cancer will add about 10 years onto your reproductive age. So if a woman of 35 has chemotherapy, her fertility will be around that of a woman who's 45, which is much reduced. To help women make decisions about fertility, and these are decisions made under pressure with very short amounts of time, Michelle Peet, who works with me in Melbourne, has developed this decision aid, which is freely available through the BCNA website, can be downloaded, And this is designed to help women navigate those very difficult decisions about fertility around the time of their diagnosis. So menopause affects all women. It's a normal thing, and all women go through menopause around age 50. And it's called premature if it's under 40 or earlier or under 45. And chemotherapy for breast cancer commonly leads to premature or early menopause. And removing both ovaries, which might be done as a risk reduction for high-risk women or potentially as part of the endocrine therapy that Rick described, that will lead to immediate menopause. As well as that, the kind of treatments that we've discussed for hormone receptor-positive breast cancer, such as tamoxifen or aromatase inhibitors, can cause menopausal symptoms even in a woman who's already gone through menopause. So she might have had symptoms many years ago that then come back on these treatments. And the kind of symptoms that are common at menopause are hot flushes, night sweats, which can disturb sleep, and also vaginal dryness, which can cause pain during sexual activity, but also sometimes discomfort on a daily basis. So we run a service which is specifically targeted to support women who are having these kinds of symptoms. Hormone therapy, hormone replacement therapy, the terminology is very confusing, but drugs that include estrogen should be avoided after any kind of breast cancer. And what's been really exciting in the last few years is the emergence of new evidence around drug-free treatments and non-hormonal therapies which are effective for managing menopausal symptoms. And I've listed some of those here. We have a clinical trial running at the moment at the Royal Women's Hospital, and for those that's in Melbourne, and for those who are around other parts of the country, there are centres for this trial running at other locations. And if you contact use the contact details there on the slide, we can help direct you. And this is specifically targeting women who have gone through menopause and are experiencing hot flushes on their endocrine therapy, so on tamoxifen or aromatase inhibitor. So if these are your circumstances, please feel free to contact us about this clinical trial. And Kate mentioned getting high quality information at the right time. So I just wanted to flag up this Cancer Australia publication from 2016 that has two units, one for clinicians and one for patients, about managing menopausal symptoms after breast cancer. I think this is a valuable evidence-based resource, and it's also freely available. I've just given the website there. So sexual difficulties after cancer, many patients say that nobody ever asked me, and if they are asked, then often the answers are not very satisfactory. And sex is complicated, and almost everyone finds it difficult to talk about sex. And there are complicated reasons why this might impact on you. But I just wanted to flag up how important this area is to many women, and some options that are available now. So vaginal dryness, Rick mentioned, a very common symptom, particularly in women who are taking aromatase inhibitors. I dissuade you from using products like moisturizers because they haven't been shown to work and they're expensive. We've done a trial looking at lubricants where we showed that the silicone-based lubricants were better at reducing pain than water-based lubricants, but basically pain was still very common. Vaginal estrogen at the moment is the most effective treatment, but there is differences of opinion amongst oncologists at the moment about whether it's safe to use vaginal estrogen after breast cancer, and that's something that we can discuss. There was a mention of sleep and how common that is. Most women experience sleep disturbance after breast cancer, and it goes without saying that the burden of cancer, fatigue, mood, and daytime function is only worsened by this kind of sleep disturbance. So I just wanted to flag up some available cognitive behavior therapy. These are online treatments. They've all been proven in randomized trials to improve sleep, including in women in breast cancer, and these can be accessed from the websites that I've listed. So in addition, with colleagues at the Peter MacCallum Cancer Centre, we've recently developed and evaluated this program called CanSleep, which is specifically targeting men and women who experience sleep disturbance after cancer, and that can also be freely accessed. So finally, I'm going to talk about mood disturbance. Of course, depression and anxiety are more than twice as common in women compared to men across the lifespan. And for those women who've previously experienced depression or anxiety, those who are socially isolated, there's an association there with alcohol abuse and also financial hardship, and we know these are major issues for women who've had breast cancer. And just to flag up how the end of treatment is a particularly risky period for women who have experienced cancer. So in terms of managing mood, information is important. There are online treatments as well as in-person psychological therapies which are effective. Some of the antidepressants help with hot flushes as well as helping mood. And of course, looking after yourself, finding ways of dealing with anxiety and finding out about financial help that might be contributing to these concerns. So in summary, it's common, as Kate has indicated, for women to experience infertility, sexual difficulties, menopausal symptoms. There are effective treatments available which are safe to use after breast cancer, and some of those don't involve taking medication, which I think is very important to many women. In Victoria and Western Australia, we have multidisciplinary services available to help support women after breast cancer and to help them stay on their endocrine therapy. And I just wanted to flag up this new program, the Women's Wellness After Cancer, which offers online information and also the opportunity to talk to a cancer nurse for support. Thank you.
Thank you, Martha. Is that program available nationally or only for people in Victoria?
So the Women's Wellness After Cancer,
Yes.
that's a Queensland-based program,
Sorry, yep.
and yes, it's available nationally. And they're just developing a new targeted program for young women with breast cancer.
Fantastic. So make sure there is a lot of information in those slides. So what we can tell you is you can go back and watch this webcast afterwards, but also we will make sure that we have some of those key programs that Martha spoke about. So thanks so much. There are so many questions. I'm not sure how I'm going to facilitate this, but Virginia truly needs to live inside me to make sure that I can execute these. But one question that has come up a few times is about prednisolone and its ability to help people with some of the side effects.
Prednisolone?
Yeah.
Oh. So prednisolone is a steroid?
Yeah.
Yeah, which is interesting. I mean, prednisolone certainly as an anti-inflammatory can help with joints. I mean, it's used for people with rheumatoid arthritis and sometimes osteoarthritis. I mean, steroids as your first go for someone who's got a lot of joint problems perhaps wouldn't be my first thing I would go to, because they do have side effects, particularly if you're on them long term. And the joint problems with the medications such as the aromatase inhibitors is not a short-term problem. It's there sort of almost while you're taking it. And so if you are taking for 5 years, then the joint issue can last that long. So I wouldn't have thought prednisolone's a great option for that long. If someone needed that much intervention, I'd be really seriously thinking, is this the right drug for them?
Yeah, great. Martha, anything to
Yeah,
add
look,
to that?
I can completely agree. There's a real lack of good quality evidence about treatments for joint pains associated with aromatase inhibitors, but I'm not aware of any high quality evidence that prednisolone is effective, and I agree that it has risks.
Just a couple of things. The things that have been shown in women with the joint problems, one is exercise programs that clearly have been shown in nice trials to decrease the pain. And I always encourage people, it can be a bit of a vicious circle though, of in so much pain, how can I exercise? And if I don't exercise, I can't get better. And actually, acupuncture has been shown to be effective. There's a nice randomised trial in the US that showed that good acupuncture can be helpful for
I'm
these
trying
things.
that at the moment.
Yeah.
And it's very interesting. In 2006, when I started at BCNA, at our forums, the women were talking about the benefits of acupuncture, and now the science has caught up to their own personal experiences. So it's been great. One other slightly controversial one that's come through is about medicinal marijuana for pain relief. Any thoughts on that?
From personal experience, I don't know. I mean, marijuana and cannabis are very complex in the cancer world, and lots of different things are put out by them. My pain specialists and I suppose palliative care specialists, who probably know a bit more, it's pretty variable, the benefits from it. It's not quite as good, I think, as people would like to think. As a cancer treatment, there's no evidence to support it. There are, for nausea or pain, I mean, obviously some people say it's great for them, but the trials are not that impressive.
Yeah, so I think the most important thing when you're trying anything is to make sure that your oncologist is fully informed of everything that you are taking, whether it's supplements to any other types of treatment. Martha, weight gain comes through and through. Any advice on that and acknowledgement of it being real for people?
Look, we all gain weight as we get older, and actually picking apart what weight gain is due to treatment and what's due to limitations because of surgery and other therapies is difficult. Menopause itself doesn't cause weight gain, but we do get a redistribution of the fat when places that we don't want it to go. It is distressing, and not only the women not want to gain weight. There is, of course, an association between weight gain and the increased risk of breast cancer recurrence. So I think active programs, some of the BCNA are obviously involved in supporting some of those, but keeping active is really important. No, I don't have any instant solutions, though, to preventing weight gain.
So I'll go on now to some of the younger questions that have come through, Rick, around pregnancy and when you can go off the hormone therapy to have a child. There's actually been, or that to try and have a child. Any advice on that for the younger women?
Yeah, I mean, it's a great question and a really, really difficult area. I mean, I still come across sometimes people who have been told by someone, oh, you can't have a baby after breast cancer, full stop, end of story, which is actually not true. I've had plenty of patients who've had babies after their breast cancer diagnosis. All of the evidence that has been picked up over the years, really through following women who've had babies, have never suggested that a woman who has a baby after breast cancer has any higher risk of recurrence than women who don't have babies. So that's, I think, always reassuring. What's complex, though, and there's a little caveat there, the data's not fantastic. We don't really know about stopping your treatment early to have a baby. You know, should you have 2 years, for example, of tamoxifen before, or 3 years, or should you stick to the 5? It's not an option for some women. If you're 39 when you're diagnosed, and someone says, oh, you have to have 5 years of tamoxifen, you say, well, I'll be 44. So it's a really difficult area. I'm certainly comfortable with patients who have got a couple of years down the track, if they're really committed to wanting to try and have a baby, to stop their treatment, and you have to stop the treatment to try and have a child. That's my style. That was my teaching, you know, when I was in the UK, etc. But I accept that not everyone feels so about it. The Europeans are trying to put together some really good data on this and trying to collect better information about women who get pregnant after breast cancer. What have they done so far? How much treatment have they had? When did they stop it? All those things, so that we can perhaps give better advice, because it is very variable. I think you'll see different people and they'll have slightly different feelings about it. I think it's a fantastic thing if people want to try and do it and can do it, but yeah, there's not a consensus there.
So following on from that, our recent Beacon magazine had a story on taking a holiday from hormone therapy. And in fact, Catherine is in the Melbourne area who is taking a holiday currently from it. Any advice on what's the right amount of time to have a holiday from it on, or?
Yeah, well, that's another great question. The first thing I would say to Kate if she saw me is take a holiday from the tablet. Have 6 weeks off. Keep a diary. I've had this conversation at least 3 times today. So I think early on, when the symptoms are overwhelming, whether it's in the first year or 2, one of the really interesting things is if you have a 6-week break off the treatment, and why 6 weeks? You need some time to get it out of your system. You need some time for those hormones to recover a little bit and maybe relieve some of those side effects. And if you keep a diary, one of the interesting things at the end of 6 weeks is how many of those symptoms disappear, how many are unchanged, and how many get a bit better. Because that will tell you what's the tablet doing and what maybe the menopause that the chemo caused is doing. Because if it doesn't change in the 6 weeks, it's not the tablet anymore. If it changes dramatically, it's definitely it's probably the tablet. I always say you've got to go back on for 6 weeks, keep the diary and see if the symptoms come back or don't come back, and then come and see me and we'll talk through it. Strangely enough, sometimes having that short break, some of the symptoms don't come back as bad the second time. We don't understand it, but I certainly see that. And that's worthwhile in itself. Knowing which ones are due to the tablet and which ones are not due to it is important. Because if all of them are due to the tablet, you've got to say, is this the right tablet for me? Second answer to that question is if you're having treatment from 5 to 10 years, so you're well down the track, there was a very nice trial done called the SOLE trial, SOLE, which built in, one group took it every day for years 5 to 10, and one group had 3 months off every year. They actually did it thinking it might work better if you have these breaks. It turned out they were even, so you didn't get more cancer back if you had those breaks in those second 5 years, but the quality of life was much better. Because having that break sometimes just rejuvenates a lot of things. So in the second 5 years, up to 3 months can be optional. I think in the first 5 years, I'd be a little bit nervous about that long, but I have a lot of discussions, seriously probably 10 or 15 a week with patients say, why don't we have 6 weeks off, keep a symptom diary, see how things play out.
Kate, have you tried a holiday?
I did try a holiday, and I did have a big improvement in the pain in my which was significant and very distressing in the balls of my thumbs. I came back on not as bad. Everything else went back to how it was, but that was the improvement.
Martha, there's a few questions on cognitive, and you spoke a bit about options for cognitive therapy. What new research is coming in that whole area? It's fascinating to me how people kind of were like, yeah, you have chemo brain during chemo, but now everyone's worked out that actually chemo brain does continue long after treatment. So is there any new research that's coming out in this area?
So the research that I was talking about in my presentation was about the use of psychological therapies such as cognitive behaviour therapy to improve menopausal symptoms, also to improve sleep and to improve mood, not specifically about the kind of changes in thinking or memory that might be associated with chemotherapy.
Mm-hmm. So, I mean, Kerry has been talking about some severe impacts that she has had on her cognitive dysfunction. I think we would all agree that it's very important to just keep those lines of communication going forward. And I think Rick really identified something that's very important about people keeping a track of things, because I think by the time they go into an appointment with you and they're trying to remember back to where that moment in time was is really tricky. So I think for anyone having any issues, then writing a daily diary is probably the best way to make sure that they can get the best out of their next consultation. Any other advice on that kind of impact?
Yeah, I mean, just quickly on the cognitive, chemo brain, I think it should be better to be called cancer brain, because I have patients who have never had chemotherapy who have, so-called chemo. It could be hormone brain, it could be cancer brain, it could be post-surgery and anaesthetic brain. I think all of them can add to it, and it's a very real thing. We don't quite understand exactly why it happens, but there are some good people sort of trying to look into that and research that in Australia, but trying to understand what it is and what could be done, and we don't have great solutions. Memory and concentration are usually the things people really complain about. And of course the irony is the patient comes to see you and says, I had all these problems to talk about, I can't remember them. So I said, well, that's problem number one, is your memory. So obviously, notes and writing down the questions and bringing them in is good. But it's a very real thing, and I don't think we have an easy solution. People are very adaptable, hopefully. Quite a lot of patients, as the years go on, somehow seem to work a way around, or to cope with it. It's amazing what people can cope with, but it's not nice to do that, and I wish we had better answers for it, but it is a real problem.
And I think our advice would be that coping doesn't mean staying silent about your issues. And I think in the past, we have certainly seen many members just thinking that they're being a nuisance to their medical team by bringing up some of the issues, particularly about the impact on their sexual function. And, we at BCNA really want to lift the DINA on that kind of topic. So another, Sylvie has talked that she had no chemo, but actually from her letrozole, her side effect has been hair loss. Martha, do you want to talk a bit about that?
So that's not something that I've seen commonly, but I think it's very important with these medications for women, as you say, to speak up and report all the consequences that they can get. Some women do experience hair loss over the menopause transition, but I'm not aware of any good treatments to either prevent or manage that. Of course, there is now access to treatments to try and prevent hair loss during chemotherapy, but not as far as I know with endocrine therapy.
So Beck, who is in her 40s and wasn't in menopause, is on Femara. The chemo and tablets have stopped my period. Does that make me postmenopausal now?
Yeah, so it's a very good question. And menopause, here I'm talking about menopause when I've got Martha next to me, but very complex area. And clearly a lot of people have chemotherapy in their 40s particularly, their periods will stop and their ovaries presumably have stopped. One thing always to remember is just because you don't have periods doesn't actually mean your ovaries aren't working. So if you're being put on a tablet like letrozole or an Astral Femara or etc., and you're in your 40s, the person putting you on it needs to make sure they keep a bit of an eye on your, to make sure your ovaries aren't waking up, because the tablet won't work if your ovaries are still working. And sometimes they can be working without you having periods. So it's got to be monitored quite closely, particularly if you're in your earlier 40s, because ovaries can wake up sometimes years later. So that has to be watched quite carefully. But yeah, if you've had chemotherapy, you've gone into a menopause, it's been shown by blood tests that your ovaries have stopped working, there is the option of using a drug like Femara. There is the option of using tamoxifen as well. Depends a little bit on the type of cancer you've got and the risk about it. But main thing is, if you're in your 40s on Femara or Arimidex or whatever, and your ovaries are still sitting there, they can sometimes wake up later on.
I might just flag up a couple of new developments and research that's in progress. So going back to the question about taking a break to get pregnant, there's a big study going on in the US which is specifically trying to answer that question. When should you take a break and what might the consequences be? And we have a study running here in Melbourne called Forecast, where we're bringing in data from all around the world of women who've been treated for breast cancer before menopause to help to design a tool so that individual women can predict their chances of fertility or infertility after their breast cancer treatment.
Fantastic. And I think that is a really good point. We've spoken a lot about the new research that's coming through, and daily our inboxes are full with new findings and latest research. And I want to remind everyone that you can receive a monthly newsletter from BCNA that specifically looks at providing our members with the latest in research, and that's called the Network News. So if you're not receiving a monthly email from BCNA specifically on latest research and information that's new for people who have been affected by breast cancer, then please call our helpline to get that. Now, there have been so many questions that have come through. I love, Judith is asking, is it worth taking therapy for an 81-year-old if there's so many side effects?
Great question. I saw a 92-year-old today who was talking about various treatments. So, I mean, age should never be used by itself as a barrier to discussing things, because there's lots of 82-year-olds out there are amazing and may well live for 10, 15, 20 years and don't particularly want their cancer to come back either. And so I think they need to have an open discussion about which treatments may be appropriate. I think ultimately, if you go down a hormone pathway and the side effects are just too great, well then the question always is whether we stop them. I mean, there are things we can do. We can change them around a little bit. We can have breaks. There are some things we can try and sort of move around. But ultimately, in the end, if the side effects day to day are too much, then you've got to say, is it worth it? Is the short-term pain worth the potential long-term gain? Remember, most people I see could well be cured by the surgery alone. We've always got to remember that. We're trying to build on that cure. So it's not like if I don't take the tablet, I'm doomed for my cancer to come back. That's not true at all. It's sort of trying to improve your odds. And if the side effects are just too much, then that's a very reasonable decision. Sometimes I just don't want to, I can't do that.
I think it's a really big challenge for us going into the future around being able to effectively communicate to individual women and men who've been diagnosed on the probability of what a treatment is, because it's really hard to understand statistics and what does that mean for me and making the best decision for me. And I really want to encourage our members to be much more involved in making the decisions that are right for you based on what's going on in your life right now, and having those very open communications with your health team. Martha, we are nearly out of time, but I wanted to say we have many members in regional areas who just don't have access to quality programs for menopause. What is your best pieces of advice for them?
So we have recently developed and rolled out a telehealth service at our menopause and cancer service based at the Royal Women's in Melbourne, and that's a statewide service. And we're very happy to see women for their first appointment or ongoing appointments through telehealth, recognising the challenges that there are for rural women.
Fantastic. And so we would encourage everyone to reach out for that as well. Rick wants to...
I just wanted to say something, sorry, that just came to mind there. I mean, and sort of Kate brought it up with in terms of compliance and taking the tablet. I think one of the things is if you're finding it too difficult or you want to stop, I mean, you've got to discuss it and talk about it and let us know. I mean, I think the thing that I'm always worried is someone says, oh, I can't tell him I'm not taking it because it's too bad. I'll pretend I am, and they're not. I think you need to be honest and open about it so you can discuss why you've stopped it and what could we potentially do to try and work around that rather than pretending. And you know, you say it happens. I mean, people have done sort of work and stuff overseas in particular, and anywhere from 10 to 40% of patients over the 5 years stop taking the drug, and a lot of them don't, you know, articulate that. They just sort of take the script and throw it away. So that doesn't help anyone, and I think if we don't know the problems, we can't really help try and solve them.
There has been one question come up about natural therapies and in particular turmeric.
So
Martha.
many women want to use natural therapies, and why wouldn't you? And I think one of the most exciting developments over the last few years has been the number of studies which have tried out a wide variety of natural therapies and also non-pharmacological therapies to see whether or not they're effective, mainly for menopausal symptoms after breast cancer. And we can now say there are certain things that work and there are certain things that don't work. At the moment, there isn't anything that you can buy across the counter or from a herb or any other kind of source which has been shown to be effective. But there are non-pharmacological treatments such as hypnosis and for some women acupuncture, which are effective. So you can use natural therapies, but just be wary of buying certainly any products that are considered bioidentical because they'll often have strong hormonal effects.
Martha, we could do a whole webcast on sexual wellbeing, and I think we probably will, but there has been a lot more talk about Mona Lisa across the country at our forums. Can you tell us a bit about Mona Lisa first of all, and then the evidence behind it?
Sure. So Mona Lisa is a type of laser treatment. There are several different sorts of lasers that have been used for some years in the setting of cosmetic surgery around skin with the idea of trying to lift or tighten various parts of the body. And relatively recently, these devices have been used in the vagina to try and treat symptoms such as vaginal dryness or what women perceive as a loss of tightness, perhaps in the vagina. So I warn women away from using these devices. The several international bodies have also come out with these warnings. And the reason for that is because, first of all, they may have risk. These lasers work by superficially burning the skin. That's how they act. And we're starting to get some data suggesting that there may be long-term pain associated with the use of those lasers vaginally. And the second reason is that we don't yet have evidence that these work. So I think for women who are considering vaginal laser, they're very expensive. The person offering it to you has lightly invested in the large cost of buying a machine, so maybe quite motivated to recommend that you use it. And there are risks, and I think we should have learned from perhaps what's happened with the vaginal mesh in the last few years that I recommend women not to put non-evidence-based devices in their vaginas.
Thank you, Martha. And just one final question to you, Rick, and I'm giving you a warning, Kate, that I want you to give some reflections of tonight, but bone density and the impact that hormone therapy can have on that. Some tips on how people should be looking after their bone health, but also what monitoring should happen during that time.
Yeah, so bone density is a big issue whether you're young or old. I mean, menopause affects bone density because estrogen is really important to help with bone strength. And clearly, I've been talking tonight about treatments that are anti-estrogen, so almost by definition, they're going to be a bit anti-bone. And really, the aromatase inhibitors like letrozole and anastrozole are particularly like that. They were predicted they would be because they're so effective at removing estrogen. So monitoring your bone density is really important, and we use bone density scans for that, and that's a whole discussion in itself about accessing them and how often to do them. And I'm very keen to watch very closely, particularly in younger women, because they can lose bone density quite quickly, particularly if they've been pushed into menopause by the chemotherapy. Best treatment for bone density, or best thing that everyone can do is the lifestyle stuff. So lots of weight-bearing exercise, so basically walking on sort of harder surfaces, which can be difficult if you've got lots of joint pains. Making sure your vitamin D is sort of up. I'm a big fan of vitamin D supplementation and checking that. And making sure calcium is good in your diet is probably the best way to do it. But if you're completely non-dairy, then you might need to take a supplement. But they feel that eating the calcium, taking the vitamin D and doing lots of walking. If bone density is really low, however, then there are treatments for that. Most of my patients don't particularly want any more treatments from me, but if the bone density is really falling and you're 55 or 58 and we want you to be around for 40 years and we don't want you ending up with bad osteoporosis, there are some good treatments, but they have to be thought through because they have their pros and cons as well. But yeah, bone density is a really interesting area and bone health is super, super important. Yeah.
Yeah, and I can tell you that it's one of our key advocacy areas around making sure we get those bone density tests covered, but also some baseline data being done so we can actually see the impacts. So Kate, we always like to end our webcasts on the voice of those who've been affected. What would be your biggest advice to people out there?
Oh, it's very individual. You have to advocate for yourself. You have to go get the information because you're not going to be given it. I've had my treatment in the private system and a lot of this stuff has never been discussed with me. So if you are going down that route, I think you need to do your own research, get online, ask questions. I don't think I've got any advice beyond that. This stuff is hard. It's hard to do and you have to steel yourself to do it.
Yeah, so perfectly put. But for those people who do find it really challenging to speak up and challenge the system, our best advice to you is to call our helpline and ask our nurses on the helpline to help you navigate the system, but reach out to the programs that Martha has talked about or take someone with you to your consultation who can speak up for you. And the best bit of advice, I think, is to really look at your symptoms, write them all down regularly, every day, at the end of the day, write down your symptoms so that you can have the very best impact when you go and meet with your medical team. So it has been a pleasure to be with you. Thank you so much to my guests. We have gone way over time, but that always happens when we have so many questions we didn't get to. We will look at those questions and then try and make sure we address them on the website. If you are watching this post, so not live, then you can call our helpline for any information on 1800 500 258, and please make sure you continue to provide support for BCNA in telling us what are your issues so that we can be the very best voice we can for all Australians affected by breast cancer. So thank you very much. I have no doubt there will be a second version to this webcast, and please help us to promote the webcast to all of those in our network. Thanks for joining us.